and welcome everyone to the all-in concept. Um, this is not necessarily a new concept, but it is something that I think, as you will see, it is something that we are very excited to be able to share with you. But the first thing we're going to do, I know it's been a long day, but we're going to have a quiz. So, and you don't necessarily need to even put this in the chat box or the question Q&A, but if you'd like to, it might be interesting to all to be able to kind of see kind of where everybody's at. But here's going to be the question. I am going to show you a series of slides, and I would like you to be able to try to determine which is the implant. So here we go. Here's the first one. Where out of all of those, which one is the implant? Some of these are easier than others. I'll give you a little bit of time. I want you to really look and try to figure out which one is the implant. This is a good indication of the problem with implants today. But I'll let you take a look. Okay, here's the next. Some of these I'm going to go a little bit faster. So you got that one? Here's another one. Here's another one. Which one is the implant? And this is the last one. Okay, with that, let's talk about what percent of general dentists worldwide place implants today, worldwide. So I want you to think, what is that percentage? What's the percent of general dentists worldwide that place implants surgically? Now, I realize that this is a little bit, this was back in 2016. Numbers have changed a little bit, but I don't think it's changed that much. If you really look at it, what we're looking at is 80 to 90% of general dentists worldwide place implants. Now, let's look at the US. Same question. What percent of general dentists, but in the US, surgically place implants? So if we look at this, what is it today? What is it roughly today? It's about 10 to 15%. I've seen the number as high as 30%. I'm not sure that I actually believe that. As I go around the country and teach, this number is about where it's at, about 10 to 15%. It could be in the 20s, in my opinion. But according to dental economics, this is what it was at 2016. So here is what we know about implants. And if you really look at it, most of the implants that are placed in these two stages. So what is the traditional way of doing implants? That we're going to call this a two-stage. In 1977, really this is a three-stage. It is Dr. Brandemark is the one who talked about this. And that was extract the tooth, wait 4 to 6 months to let the bone completely heal, place the implant, wait another 4 to 6 months, put the final abutment and crown, and you have a restored tooth in 8 months to 12 months. Now, if you really look at it, what is the next evolution of implants? You would be immediate placement of implant after extraction. So known as an immediate placement. Immediate implant. That is known as a stage 1 in dentistry today. So with the stage 1, that was developed in 1989. And it's basically what it is everything is kind of the same. You extract the tooth, but you're not waiting. You immediately are placing the implant. You put your healing abutment. You wait 3 to 6 months. You take your final impressions. And so you're cutting everything down in half the time. And I would say that that's not a new concept to most clinicians and most people that do surgery. But again, the majority, if you look at the research, majority of implants that are placed is still in that 3-stage way of doing things. And then the rest, almost all of them, are in this stage 1, except a few that I'm going to show later on. So what is the problem? And I try to come up with 5 problems with immediate implants. So that's extraction, placement of the implant, in the extraction socket same day. So what would be those 5 problems? The first is, and this first slide is actually in the two-stage process where you're taking the tooth out and letting everything heal. So we take it out, and we see this all the time. If we let the bone completely heal, sometimes we end up with no bone to be able to restore. We get that all the time. So if we place an implant the same day, do we get less of that resorption of bone? My theory is that yes, we do absolutely get less. The problem is that we have, let's just take a molar. It's 10 millimeters by 13 millimeters sometimes. We got this great big gaping hole, and we put this implant in that is 5 millimeters. We put a healing abutment on, and what do we get? We get loss of papilla. We get loss, and we know this. We know that the bone is going to actually be the worst resorption is going to be from which side? It's always the buccal side. So the buccal bone is much thinner than the lingual bone. We'd get a little bit of resorption in that. And so if you look, they did a research in 2023, and we've known this. And if you look at this, I got to move this so I can read it. The most significant changes take place in the first 6 months after tooth extraction, with an average bone resorption of almost 4 millimeters, 3.79 horizontally and 1.24 vertically. So in the first 6 months, we have a tremendous amount of bone loss. Now, if we put an implant in, it's not going to be as much. But is there still going to be a lot of bone resorption? Absolutely. That's the problem. The second problem with immediate implants is that we have an increased risk of infection. So we place these implants. We have these gaping holes. Again, let's just take that scenario of where we take this 10 by 13 millimeter diameter molar, and we place this implant that's 5 millimeters. How do we seal that? How do we seal that socket? What we end up with is we end up sometimes with an excess amount of bacteria that gets into the threads of the implant, and we can end up with an increased risk of infection. We have primary stability challenges. Because we don't have as much bone completely surrounding the implant as we place it, we end up with inability to be able to have that primary stability that implants need. So let's just look at this. And if you haven't seen this chart, when you truly are looking at implants, you need to understand how bone is formed. And I actually will take with patients, and sometimes I'll draw this. I'm doing an all-on X. I'll say you just simply cannot chew on this because of this chart. And I'll go in and I'll say, okay, here we go. We place this implant. Let's just say that we have 100 newtons and of torque. And I use that, but let's just say that that's the stability number that we have. What ends up happening is for the first 10 days, nothing happens. Nothing happens in the first 10 days. That stability starts coming in. But then we have osteoclast and osteoblast activity that happens around the implant. The stability then goes dramatically down. So if you look at it, what is the problem? When the patients feel good about their implant and they have no more pain is when it's the most vulnerable for them to chew on it. And so it's right here in the weeks of 3 and 4, because we have osteoclasts that end up destroying the bone around the implant. Then osteoblasts start coming in and they start stabilizing the bone, but that doesn't take place until around week 8. And so that's why we tell patients, you cannot chew on this on an all on X, it's a liquid diet for 2 months. And really the stability, this keeps going up and up and up. So that's one of the problems, is just stability. Yeah, the biggest issue that I think, well, I would say bone is the biggest issue, but right behind that is tissue. So what happens is when we place this again, 10 millimeters, and we end up placing a 5 millimeter, you have this gaping hole, we get a loss of the tissue, the attached tissue as well. And so what ends up happening? We end up taking and removing the healing abutment after the 4 to 6 months that it's healed to take that impression. We've ripped the attachment. So let's look at that. If you look at what happens with a tooth and do we have biological width with a implant? Absolutely. We have junctional epithelium, we have hemidesmosome attachment or Sharpie fibers, whichever way you want to look at it. But is it as strong as it is on a tooth? If you look at the junctional epithelium on a tooth, it's very well organized. Is it organized on an implant? Titanium, zirconium, does it matter? And how strong is that attachment? I think this slide shows it best. Here is the strong attachment of the hemidesmosome layer that is attached, or the Sharpie fibers from the tooth, from the attached tissue to the tooth. It is extremely organized, extremely strong. You can see that. Here it is on an implant. It is extremely fragile. And so what do? We let this thing heal for 3, 4, 5, 6 months. That fragile attachment, what do we do with that healing abutment? We rip it. We rip it off. And then we put an impression coping or a scan body, and we put it in. We take, 30 minutes to take that impression. We then rip again. Then what do? We put that same healing abutment that has ripped Sharpie fibers, and we put that right back on. We might clean it with even chlorhexidine, but we're putting it right back on. Are we going to get as strong of an adhesion of those Sharpie fibers back the second time? There's no way. Then what do? 2 weeks later, we go to put the crown on, and we rip it again. And we either put a cementable abutment or we do a screw retained, but it's never going to be as strong. I've heard it say that we might only get 5 rips in our lifetime, and potentially will never be as strong as the original. So just want everybody to understand that. The other is it's a higher risk of complications when you do an immediate placement of implant in a socket. For the reasons that we've talked about, you can just end up having more of a problem. So I want to look at a KOL slide. This is from one of the implant manufacturers. And I'd like to go through these slides, and when I'm live and I'm actually teaching, we'll go through this, and I really want you to go through and say, okay, let's look at these slides with a fine-tooth comb and try to figure out, is there anything wrong with this? It's a very interesting slide series, and so we'll go through it, and I want you to think in your minds, what are the things that I see potentially that isn't right with these slides? Remember, this is KOL, key opinion leader of this company, an implant company, and this is kind of like showing this is a case that they're extremely proud of. And I think it's a good case. It's a beautiful ceramics when you start to look at it. But here we go. That same case that I looked at, I want you to look at this objectively. And again, where is the problem? When you're looking at something like this, the telltale sign of an implant is usually the gingiva. A great ceramist can make it look very similar to the natural teeth that are around it. But when you look at the gingiva and the bone, that is a problem. So have you spotted it yet? Have you seen the problem? Let's go through it. So here is the extraction socket. Is that good? If anybody has done a lot of extractions in their life, you're going to have sockets that look similar to this. I would say that it is not perfect, but it's not horrible. There definitely is buccal bone. We got lingual bone. We got septal bone. So overall, this is a pretty good extraction socket. We can see the teeth. They separated the teeth when they removed this. I'm sure that they removed a lot of anything that's in the socket itself with a spoon. And it looks like that here's the placement of the implant, immediate placement. Now, I've heard a lot of different opinions. Is this the right spot to place that implant? In my opinion, I think it is actually a very good spot. When you're looking at a lower molar, which is the number one most replaced tooth by an implant, is a lower molar. We want to be, because of the curve of Spee, we want to be in the mesial aspect, mesial root of that tooth. We can be right in the septal bone, that's fine, but we're not going to be as strong as if you were in the mesial root like what it's showing here. There's lots of opinions whether this is right or wrong. I think it's actually a very good spot to be able to place this implant. Here is the abutment. So this is an immediate placement with an abutment. Again, even with the abutment, we have a big area that is not sealed at all. They did bone graft, which is it looks like a beautiful bone graft. Then here is the sutures. I think the suturing is very good. They bring the papilla together. They let everything heal. It's a PTFE suture, which is you can't complain about that because that's a really good suture, and it looks like a very good suture technique. So they're going to let that heal. I want you to look at the healing. What do you think of the healing? I want you to think to yourself, does that look good? When you look at this, we've got great attachment around it. It looks absolutely beautiful with the attachment around. But what do we see? Is there any problems with this? What I want you to really pay attention to, see if I can get I'm going to go back. Okay. And my arrow is not working. Just distal. Oh. It's not letting me have an arrow. I want you to look just distal to the implant. What do we see? We see bone loss, and we see a tremendous amount of bone loss. And so that is the problem that we face when we do immediate. So if we do a stage 1, we're going to be even worse than this. So if we took this tooth out and we didn't place the implant, that mesial root area would be exactly like that distal area. That's exactly what that study is showing us. So is this a good scenario? This actually saved the patient because it would have been just like that in that mesial area if that implant hadn't been placed. But is that a problem? Let's go through it. Beautiful tissue. I would say that this is a gorgeous tissue adaptation to this implant. Remove that abutment. Here is what the lab is going to make. So they've got they digitally put this together. And the question is that good? They had to do like a little ovate ponic, mini ovate ponic on there. I actually think that the lab did a phenomenal job with the way that they made that. If they would have just come completely out, it would have been more of a bacteria trap. And so aesthetically, they did a phenomenal job in being able to make this crown. They matched the adjacent teeth beautifully. So this is beautiful work by the lab. But here's the problem. I want you to really look at the amount of bone loss. Do we accept that? Is this acceptable in your practice? Because this is the norm. This is what we see, especially with posterior teeth. So this is an immediate placement, a 2-stage implant, I guess you would call this a 1-stage implant in today's vocabulary with implants. If you look at this, there's no papilla. a tremendous amount of loss of bone. The x-ray looks beautiful. The bone has adapted to the implant extremely well. It's going to service the patient well, but what's the problem? The problem is that bone loss. So when you look at it, it's that tooth number 19. That's the problem. There's no bone. And so what do they have to do? What's that patient going to have to do the rest of their life? They're literally going to have to use a proxy brush, and they're actually showing this in this KOL slide, that this is the way that the patient is going to have to be able to clean this, because there is no interproximal papilla. Food is going to collect in there. It's going to be a mushroom. Patients are going to have, everything is going to be attracted to there. We just accept this for our patients, and we say, okay, this is the best that can be done. Is it the best? So that's what I'm trying to show you. Is this the best? So what I did is I went to Google, the wonderful Google, and I typed in successful implants in the posterior, and this is what it brought up. And so this is the norm. Here's another one, exactly the same thing. Here's two implants together, exactly the same thing. Loss of both horizontal and loss of vertical dimension of the bone. Now, I don't know whether these were immediate placement. I don't know if this was delayed placement, but regardless, this is what we traditionally will see with implants today. Is there a different way of doing this? So this is what I have been working on for probably the last 8 years. And we have this, the process of a different stage. So let's go through the stages again. We have stage 3, stage 2, and stage 1. So I changed the vocabulary to be able to talk to patients, because this is what they, in their minds, think. On a 3 stage, it is an extraction. We're going to wait. We're going to let the bone heal. Then we're going to place the implant. We're then going to wait again. And then we're going to take the impression and put the final crown. 3 different stages of healing that needs to take place. And do I do a 3-stage approach? Sometimes the infection's so bad, I have no other option but to do that. A 2-stage. This is the immediate placement, extraction and an immediate placement of an implant, same day. We wait 3 to 6 months. We put an abutment on, a healing abutment. We put the final crown on after 3 to 6 months. That's what we were just talking about, immediate placement. In my opinion, most cases should be at least an immediate placement if it doesn't have any form of infection, because we know we're going to get a much less loss of bone, because literally these are known as bone stabilizers, and it stabilizes the bone. And so we don't get as much of that first 6 months of the loss of that whole socket area. This is what we've been working on. Stage 1. Stage 1 is immediate placement and immediate loading. 1998, Palomalo out of Spain was known for this, because he's the first ones that really started doing this, and that we know today as the All-on-X. And so that's where we got this immediate loading. But we've known that, and from everybody that has taught about All-on-X, we get the cross arch stability. But is it possible to be able to do this in even a single implant? That's what we're going to talk about. And that's what the all-in roughly is. What this is, an extraction, an immediate PMMA or final within the first day immediately, or within 10 days. And so there's some clinicians that are doing it where they're actually putting the final restoration in that window of 10 days. So let's look at that. So Dr. Costa out of Dubai, he's the one that I learned this from. He looked at this and said, could we potentially But if we finished everything within this 10-day window, when we have all of the stability, and then we do not touch that tooth for that entire 2 months, roughly 4 to 6 months, teach the patient not to be able to chew. So we've got that no-go zone, and then we've got this 10 days. That's how it works. So let's look at All on X. One from our sponsor. I just want to show you some beautiful restorative work for these All on X cases. This is absolutely gorgeous. That bar is beautiful, and that's going to have a tremendous amount of stability. These are some All on X cases that I've done, and I've had great success. This is where we have this cross arch stability. This is a patient that we had finished. Talk about a case where she ended up coming from an entirely different state. Came to me. I had to take all of her implants out. We had to start completely over, because this is an All on X case that didn't go well. And it was a long process, but she's extremely happy, and it turned out very, very well. Here's a guy that got into drugs, ended up destroying his teeth. And this is an FP1 All on X. We actually did 3 different bridges, and we did this where he had the abutments same day. Hard case, but finished this. He absolutely is thrilled with this. But again, can we take a paradigm shift and say, okay, here's what we are going to do. We're going to do it a different way. Can we be able to not have all of this loss of bone, both from the buccal and from the horizontal and the vertical? Is that possible to do? So this is where the all-in implant concept has come up. I was working with a designer out of Belize. We've had a tremendous amount of different conversations, and we came to a conclusion. We have this passion. We both had this passion of how do we not have this loss of bone? And so we have worked on trying to perfect this, and we're continually perfecting it. But I want to show you one of our early cases. So what happens is let's just take this case. Patient comes in. She's a 62-year-old female. She has pain on tooth number 19. She has percussion and palpation sensitivity. She has an active fistula. She has active infection. I do it a little different now if they have active infection, but I want to show you a case that is very similar to the case that we saw from the KOL. And I want you to pick out what I did wrong. And I definitely did some things that were wrong as well. She had a previous root canal 10 years ago. It's not the best looking root canal. She wanted the tooth extracted, implant placed. So that's our treatment plan. We're going to extraction. We're going to section the roots with a guide. And what the all-in system is it gives the clinician, the surgeon, everything that the surgeon thinks that he potentially would need to be successful with the case. So I'm going to show you what this is. So here is the pre-op photo. You can see the active fistula. Very similar case as the one that I showed before. Maybe even a little bit worse. Okay, so here is the case with the active fistula. What do? So the first thing we do is we take a CBCT. We take that, we have to be able to have a CBCT, and we have to send that to our designer. This is Marius von Totter, and he's in Belize, and we have another designer in Utah. So I send it to them. It has to be a DICOM file. So you definitely want what we call an open system. He gets it all the time from places that they don't have an open system. It doesn't work unless it can be a DICOM file in an open system. Then we scan it. I've used a bunch of different scanners. What I'm finding out on scanners today, there is a plethora of different companies that have scanners. And from the research and from actually CRA, Gordon Christensen, they almost all are really good these days. Really good. The accuracy is absolutely fantastic. I just talked with my main lab guy, and I said, from traditional impressions to the scanners, the 3D scanners, what do you think? Which is more accurate? And what we're finding is that we're pretty sure that the scanners are actually more accurate than traditional impressions. And then you start looking at the cost involved. And so it really doesn't matter which one you get, you're going to save money in comparison to taking traditional impressions. That I can promise you. So right now, it's about 50-50 in the US of doctors using scanners compared to traditional impressions. There's nothing wrong with traditional impressions. It's just you have to take a digital impression to be able to do it the way that we're discussing. We always take a series of photographs. Those photographs then go to the designers as well. They get a lot of information just from the photographs, and these are the series that we take. And now it's to the point that my surgical assistants are doing all of this work when we are setting up a patient to be able to do it. And we literally call it the all-in method. So what is unique about the all-in method? What happens is they then convert it and they put it into what's called NemoScan. NemoScan is a software system through a company called Biotech. Biotech is a company in the US, and these are the majority of the implants that I use is Biotech. Biotech is actually a very, very large company worldwide. It's the #1 company in, I'm pretty sure, like 2 or 3 countries in Europe. They have like 700 employees worldwide. They place almost like 2 to 3 million implants yearly. It's fairly new to the US, but the implants themselves, I absolutely love. What's great about the software is the ability to be able to then show me where in relationship to the roots am I going to get stability for this implant? So this is how we planned it. This is what we can see. And then the other issue that is the #1 issue for me is that they can virtually extract the tooth and give me the exact dimensions of the socket. That's extremely important. There's very few softwares out there. I only know of one other. I think Straumann is working on that, but this NemoScan has the ability to extract the tooth and have the exact dimensions of, as long as I don't muck things up, to be able to show me the exact dimensions of that socket. So what do I get from the lab? This is what I get, a surgical guide. I then have a guide to be able to go through the furcation. So it's a guide that gives me an ability to be able to split the root in a very precise way. And I have an occlusal guide to be able to do just before that. So I got 3 guides, all from the all-in lab, to be able to then be very successful and know that I'm very precise. This is as well what I get from the lab. Now, this is a difficult concept to understand why I'm getting all of this from the lab. We'll go left to right. The left is a PMMA immediate temporary crown. The middle is the final abutment zirconium crown, or abutment, not crown, zirconium abutment. So it's a custom abutment to fit the exact dimensions of the socket. So we do the extraction, we place the implant, we place that final abutment if I have enough stability, if I get to the stability that is necessary. The very last one is a temporary abutment. That is, if I don't have enough stability, then that's my backup. My backup is to be able to place that temporary abutment day 1 of surgery to also seal that socket. After 4 to 6 months, then I can place that final abutment in and take a final impression just like a traditional crown. So I'm going to go through this and I'm going to show you how this was done. So here is the tooth after extraction. We place the coronal guide to be able to make sure that I remove enough coronal tooth structure to be able to put the furcation guide on. So there is, I just use a Wilbur. I go in there and I remove all of the occlusal surface area. Here is the furcation guide. This is very unique to All In. We discussed this, and we discussed how we could make this easier for clinicians to be able to go through that exactly where they need to go through. So there's guide pins. We know the depth of those guide pins, and so it's a 2 mm guide pin. We go in with those guide pins exactly where we need to go and at the depth that we need to go. And it gives me 3 holes. I then take my surgical drill and I just connect the dots at the exact depth that needs to go. And I just connect the dots. Fairly simple, and you can propriocept, you can feel exactly where you need to go from there. We then check it to make sure we're through. We see that we're exactly where we need to be. We didn't go too far. We take each of the roots out. And that's what we have. Now, here's the problem. I wasn't great. I actually pinched that tissue right, and you can see on that mesial area, I grabbed it with the forceps. And so I'm kind of mad at myself because I pinched that area, and it was the weakest area because that's where that fistula was, and that's where the drainage was. Not good on my part. But we go ahead, we clean up the sockets. Here is our drill guide. Now, this is also extremely unique from biotech. What we have is we have not only a surgical guide, but we have the exact timing of where to be able to time everything in the guide system. What is timing? It is to time the implant exactly where it should finish so that I can place either the final abutment or the temporary abutment same day as surgery. So this is the driver. I can then make sure I've got 3 reference marks. I have the right reference point, the left reference point, and the big black area. All 3 need to line up. It also has a reference point of the black line. That black line has to be below, and then I know the metal of the guide. Then I know that I'm where I need to be. If you look at this, that I actually needed to go 1 more to make sure that that black line wasn't there. And that's what we did. So if you look, that's exactly, let's go back. This is, I needed to go 1 more to be able to make sure that that black line was below that. We then get our Ostel reading. In our view, I need to be at least 45 newtons of torque, or I need to have above 70 in all directions to be able to place the final abutment day of surgery. So we got 74, and I think it was 74 all the way around. By the way, I love the Penguin when you're trying to get not Ostel, but ISQ readings. So here is the implant placement. Again, we're in the mesial root. And some people will say, well, we're too close to that, this tooth number 20. And I agree. We could have possibly brought that a little bit more distally. And I think it might be just the way that the angulation is, but we want to be angled towards the central fossa of tooth number 19. So we're taking that, we do a bone graft all the way around that, and then we place our final abutment. Now, what do we want that final abutment to look like? I want it to look exactly like if I had prepped this tooth. I wanted to seal the entire socket. We want it to seal everywhere around it. If I can seal it, then what do we get? We end up with much less bacteria that's going to invade, but we want it to look like a tooth, exactly like a tooth that had been prepped, so that if anything happened to the crown, anybody, any dentist can be able to restore it, whether you're in the US, it doesn't matter where you're at worldwide, they can be able to do something with this tooth. So this is what the all-in concept is to be able to finish these with this final abutment. If I couldn't have done this, and in our part 2 series, I'm going to show you cases where we couldn't finish it and we had to use a temporary abutment. And how we finish these cases. But in this case, we had plenty of stability. We were able to finish it with this final abutment. So we're going to go through a couple series. We put the PMMA on that final abutment. This is day of surgery. We make sure that we take it completely out of occlusion. The tissue does not look great. I will freely admit that I made a mistake there. And we're going to get some resorption of that tissue. I know we are, but I want you to look at that in relationship to the other way of doing it. So here is another view. Here is another view. Again, you can see that it's out of occlusion. We also tell the patient that they are to not chew on that area, just like if it was an all-on X case. No chewing on that area, no pressure whatsoever on that tooth for 2 months. That's what we tell them. We want to give them some responsibility. We tell them to cut everything up and utilize a fork to put it on, in this case, on her right side of her mouth. And here's another view. Here is day 1 of surgery. So this is with the bone graft all the way around it. Day 1 of surgery. Here's 3 months after healing. Now let's compare the two. So we got day 1 and 3 months of healing. Couple things that we could have done better. In my opinion, we could have used a longer tie base. We used too short of a tie base, but we still ended up with an incredible amount of healing that sealed into that implant. So the platform switch, we want bone to go into that platform switch. Not only did we have it from day 1, it actually grew into that platform switch. If you look at the zero bone loss technique, this is exactly what they do. They want to make sure and seal that socket, but what we're doing is we're sealing it with a custom abutment day 1 of surgery. This is 1 week post-op. Tissue resorbed slightly. We knew we were going to get some of that. This is 3 months post-op. Buccally, you can see where the buccal bone is. This is 3 months post-op. So we're about ready to be able to look at actually being able to take off the PMMA, take that impression. So here is where we're at. We had a little bit of resorption. So this is from the start to 3 months. We got a little bit of loss again of that tissue where I kind of pinched it. This is after everything is healed. So this is like 3.5 months. We're taking this off and I take a finishing burr. I just take that finishing burr and take the margin down just because I wanted to look a little bit better. The other issue that we did is that the zirconium for the abutment was a little too bright. And so if I was going to do this again, I would look at the root color of adjacent teeth, and that's what the abutment should look like because we want to match that as close as we can. Now, you're going to see that the crown is very white. We always make teeth a little bit wider even in the posterior, and there's a big reason why. Here is the final. And when she looked at it, she goes, oh my gosh, I need to have that back tooth restored as well. And she wanted a new crown on it. And because of she thought it was pretty ugly after she saw the new crown. So that's the reason we do it that way. It's not as the ceramics doesn't match as well. But what I really want you to look at is the bone. And I want you to see the bone and how it responded. And when you have an abutment that it mimics the exact dimensions of what the root that came out of it, what do we get? We get a tremendous amount of bone saving when we go through all of this. That's what we're after. We're after the ability to be able to seal that socket day one. And what the other thing that we get from patients, I am amazed at how many patients come in when we seal that socket from day one and they say, Doc, I just don't have that much pain. I'm amazed. And I've had even some patients say, did you do anything? Because we sedate them, we go through the whole process, and they don't know that anything has been done. We have a tremendous amount of pain management that the amount of pain that the patients go through is much, much less. So when we look at these cases, these are all cases that have been done with this all-in system. I think this one's fairly easy to be able to see which tooth that is. It looks like it's tooth number 29. You're right. It's tooth number 29. Here is the implant with the all-in system. Day one of surgery, this was placed. This is a little bit harder. Which one did you say on this one? Which was the implant? Was it which one? 7, 8, 9, 10? It's actually, there's two implants here. There's an old implant on tooth number 7, and the all-in system was done on tooth number 9 with a partial extraction therapy that I'm going to show next week, and how we do it with a socket shield. And we have a guide to help do the socket shield that makes it so much easier. In my opinion, it's one of the hardest things to do very well is a really good socket shield. Okay, so which ones did you have on this? I think you can all see that this is a bridge, but is that tooth number 6? Is that an implant? It almost looks like that bridge, is that natural teeth or are they implants? Actually, both of those are implants. I'm going to show that case next week as well, and how we did that. This one, I think, is very difficult for most people to be able to see. If you look at the gingiva, it looks almost like it's tooth number 6. It's actually tooth number 5. So number 5 is an all-in system that we were able to do all same day, along with the veneers. We did the veneers and the surgery all in one day. Again, this is a case that I will show next week and how we did that. So we're ending just right on time. Here's my contact information. You're more than welcome to take a screenshot of that, get a hold of me. The best way to get a hold of me is you guys ask for Katie. Here's another thing that you can do. Oh, this is my favorite saying. I believe the target of anything in life should be to do it so well it becomes an art. And thank you for sharing in my art. I'm looking forward to sharing the rest of this webinar next week and show you the cases and how we do some of these more complicated cases with the all-in system. And I'm going to kind of show you kind of the process a little bit more next week as well. But if you want to as well, here's a QR code, and you can go to the All-In Implant Academy, and this will give you more information on all of that. Thank you. I guess we are now in the question and answer. Yes, and it's more of a comment about why is it that we don't have as many GPs. I've asked this question all over the country, and it always comes down to, and I agree with you, is Kyla, because of the litigious society we live in, absolutely. And the other reason is that I hear often is that dental schools do not want to teach GPs. They almost make us afraid of being able to do implants, but it's done all over the world. And so why isn't it done here? If it's done right and you plan everything prior to going into surgery, it is one of the most gratifying things, and you just need to make sure and follow a few protocols. You can be very, very successful. Yes, I agree. Dinesh Burrs will work extremely well. We don't, again, there's questions on why didn't I place it in the septal bone and place it right in that septal area? Sometimes we do, but if I have a really good wall on the mesial of that root and we have a high curvus spe on a lower molar, the mesial root is a great place to be able to place that. No, we had again, the only thing that I would have done is I would have had, we had too short of a tie base. We're learning as well. This is one of our first ones that we did. It is that I wish we would have had a little bit longer tie base to be able to have a little bit emergence, the better emergence profile. What we're learning, and I think most people are learning this, is that we need to go actually a little bit deeper with our implants. We seal that socket immediately, and we end up with a really nice emergence profile. That's how it's done. Okay. Which type of bone graft you use to fill in the socket? I have used a lot of different bone grafts. I love cortical cancellous. So I started with cortical cancellous. It's a 50-50 mix. I then switched to almost all just cortical bone. Why? Because the cortical bone ends up being you want to pack that bone as densely as you possibly can. And I think that with cortical cancellous, you end up with the cancellous bone is too soft. But I have switched to now a cortical or just straight GC synthetic bone. If you have not seen this bone and seen what it will do, I am amazed at the soft tissue adaptation that happens with this synthetic bone. I've been completely against all synthetic bones. And the reason why is that in the past, when I see synthetic bone, and I've taken out, let's say, or I go in to place an implant after synthetic bone has been placed, it's just like grains of sand. There's like nothing to it. But with this, it truly turns over in amazing bone. It's phenomenal for especially sinus lifts. How do you decide to do a one-step implant and crown? At what extent or active infection? So I'm going to talk to you about that next time. So if there's active infection, what is the new protocol? What do we do? That is what we're going to talk about next week as well, because there is a specific protocol that we have changed because we've had some failures. And I think potentially what we've seen since we've changed it, our failure rate has gone down dramatically from what we've done. Thank you. You've all been great. I hope you've learned something.